Thank you very much for the opportunity today, and this lecture is based on looking at certain innovations from Medtronic which may help with increasing safety and speed in endoscopic submucosal dissection. ESD, as you know, for colorectal lesions particularly is now accepted worldwide, but we still face the consequences of a long training curve and the difficulty in instilling training programs in different parts of the world. Particularly for colorectal resections, it is important that we have other factors to take into consideration. And certainly for colorectal lesions, we would use change of position of the patient frequently in order to consider the different gravity areas and which is anti-gravity and which is gravity to help with speed of resection. This is often confounded by the multiple colonic spasms that do occur, particularly if it's a long procedure, and therefore speed is of the essence, particularly for colorectal lesions. As the procedure gets longer, the colonic spasms get more, and therefore there may be an increased risk of complications and increased difficulty in completing these lesions. It is also important for us to consider the outcomes following colorectal ESD. And this is some of the data from the literature that I would like to share with you. The intraprocedural perforation rate can be up to 6%, but the majority of these can be controlled endoscopically using clips. Fortunately, most good units have a delayed perforation rate requiring surgery of up to 1.5%. And certainly risk factors such as having a very large procedure size, large polyp size, or long procedure, or indeed submucosal fibrosis can make this worse. In addition to this, delayed bleeding can also be seen in up to 8%, and is often seen in patients that have very large rectal lesions, or in patients that have had cecal lesions, however big, because lesions itself on the right side of the colon particularly can have post-procedural bleeding if they are indeed more than 30 millimeters, or if patients have been on anticoagulants or antiplatelets at that time. What about post-ESD coagulation syndrome? And this is one aspect that we need to consider. This can occur in up to 15% of patients, particularly if there is a long procedural time and if we're using a lot of submucosal dissection and submucosal injection. And therefore, lesions that are large or on the right side can be subject to post-ESD coagulation syndrome. And certainly closing these defects can help in reducing the post-ESD syndromes. This is a randomized trial that looks at traction in colorectal ESD. This traction actually was carried out using a clip and line technique, using dental floss or suture associated with the clip to either lead to traction in rectal lesions or colonic lesions. And you can see as you randomize patients to traction in colorectal ESD versus non-traction, this clearly shows that the traction group have a much shorter procedural time compared to the non-traction group. So certainly there is some validity in using traction in colorectal ESD. I would now like to just demonstrate a case where we've used traction using the Medtronic device. This is a 72-year-old gentleman who is on apixaban for atrial fibrillation, so certainly we need to consider some sort of closure for this patient. Technically, this was a very challenging resection on assessment because a lesion was in the left colon, in a valley of a colon, so position change was not favorable. And whichever position the patient was in, this was still being pulled under fluid where the lesion was. So we made a decision that traction would be needed, and this is often the case in the colon, and had a strategy also to reduce risk of rebleeding post-ESD as the patient was on apixaban. This is a lesion here. This is an LST mixed lesion, LSTNG in some areas, an LSTG with small nodules. And endoscopically on magnification, this was feels to be benign, and areas which are JNET type 2A, one area of JNET type 2B which are suggestive of high-grade dysplasia, but no evidence of overt malignancy. The device I want to show you today is really related to the traction wire for endoscopic dissection, which is made by Medtronic. This is a schematic just showing the dissection. Initially, what we would always advocate is we would actually advocate doing a circumferential incision for these lesions after marking the lesion if it's difficult. Once a circumferential incision is made, then we can deploy the traction device. Now the primary grasper itself has got the traction wire that is attached to it, and this is clipped onto the edge of the lesion, usually on the anal side. And then the secondary grasper with a clip is deployed by grasping the wire and causing traction onto the oral side. And then we would use, as you dissect further, the traction wire actually peels the tissue back, but does not lose any of the traction itself, so making it feasible to use just one device in order to complete the resection. So this is now a lesion that we discussed. A circumferential incision is made, as you can see. This is a narrow cap that's used. Here is a device in place. The clip is deployed on the anal side, and you can see that this is a wire that's attached to the clip, and that's a traction wire that we would use. So deploying that with a good cuff of mucosa that's normal onto the anal side itself. Once we're happy with the position, we can deploy the clip. You can see there's a multiple amount of colonic spasms despite using Buscopan in this particular patient. Once that initial clip is deployed onto the anal side, the next is using a clip, a secondary clip, to grasp the wire, and then you deploy this onto the oral side with appropriate traction. What we find is that a distance of approximately 5 centimeters is sufficient onto the oral side in order to get adequate traction. Now remember, as you make your incision in the submucosa, the traction is maintained. Here it is. Here is the actual traction that you can see, and despite the lesion being underwater somewhat, because of the change of position not helping, we can still see that the traction is helping in this area, making the dissection much quicker and much safer, being able to see the muscular layer very clearly. So in this situation, because we've already done our circumferential incision all the way around, we can then continue with our submucosal dissection all the way through so that we can reach the oral side. It is really important to do a good circumferential incision and good trimming, particularly on the oral side, because this device would only really work if that trimming is adequate, so that the lesion does not fold on each other and doesn't make the finish easy. And here you can see the finish is quite easy because we've already done our submucosal dissection and trimming on the oral side, and the lesion here is now complete. The next phase now is just getting a normal grasper and grasping the clip which is attaching the wire to the oral side, and then this can be removed fairly easily. It can be removed without any trauma and removed from the body. Here's a scar from the lesion itself, quite a large scar, and often this area, which is 75% of the circumference of the sigmoid colon, can be difficult to close, particularly if the position is difficult, as we found in this patient, and if there is a lot of colonic spasm. So here now what we're doing is we're using something which is to coat the scar, which is Nex powder. This is a new product from Medtronic. And what we do really is that we coat this as a hemostatic agent, as a white powder under vision. It's important first to actually make sure that the working channel of the colonoscope is dry by insufflating air through a syringe through it, and then not to use suction at all after that. Insert the catheter, and then using the device with a pump, we can then instill the white powder, which is Nex powder, onto the surface itself. You can see now that the white powder is covering all of the ESD scar. It's important now that we hydrate this, because once this is hydrated, we can actually convert this into a gel-like area. So the way we do that is turn the pump down, the water pump down completely, and very gently irrigate the area of the scar. So you can see that the white converts into a blue-like gel, and this will coat the scar and reduce the risk of bleeding post-procedure, negating the need to close this area, particularly in different areas. And there we go, and that's the next powder that you can see in place. And the lesion has been resected completely, and this was a lesion that was tubular adenoma with high-grade dysplasia that was completely resected. Just a bit more detail about the next powder, which is a hemostatic spray. This is delivered by a catheter and a device that allows for low pressure delivery, and therefore this low pressure avoids a complete loss of view that's sometimes seen with other devices, and it can cover quite a large area without actually having a precise targeting. It's actually indicated for most types of GI bleeding, but also we're using it now for covering the ulcer site, particularly post-ESD, to reduce the risk of bleeding itself. The composition is that this is a hydrophilic, biocompatible adhesive material that you can see. It's got dextrans out oxidized and modified amino acids, which are two polymers. And what this does actually, it forms an adhesive blue gel that you can see after contacting water by reversible cross-linking. And that gel will actually degrade after about 3 days or so, and therefore reducing the risk of this having immediate post-operative bleeding. So in conclusion, ladies and gentlemen, I hope that what we've shown today is that traction can be useful for colorectal ESD, particularly to improve speed of dissection, and potentially this may improve safety in the future. We also certainly need to consider either closure or hemostatic agents on the scar post-ESD in patients that are high risk of bleeding, in particular those that are on anticoagulants, like we were in this case. I thank you very much for your time.